Hello, everyone. I'm Joe Rusco, the editor-in-chief of Practical Neurology, and it's my pleasure to speak with Dr. Cohen today. Dr. Cohen, please introduce yourself and tell us a little bit about your research in MS.
I'm Jeffrey Cohen. I'm a professor of neurology at the Cleveland Clinic, where I have a clinical practice where I focus on care for people with multiple sclerosis and other autoimmune disorders. And then I also have a research interest in clinical trials and experimental therapeutics.
The European Committee for the Treatment and Research in Multiple Sclerosis, they recently organized a workshop to discuss recommendations for de-escalating and discontinuing DMTs in individuals diagnosed with MS. Can you tell us about the motivation behind this decision to organize the workshop?
So we've had disease modifying therapies with regulatory approval to treat MS going back to the first one in 1994. And the emphasis for many years was on earlier and earlier treatment of MS and utilization of moderate and more recently high efficacy therapies earlier and earlier in the sequence. But we're now realizing that as patients have long-term stability and as they're getting older, the need for therapy may decrease and the efficacy of some of those therapies may decrease. But conversely, the risk of some of those therapies may start to accumulate. There's been a lot of discussion increasing recently on whether we should de-escalate therapy, go to less potent therapies, or even discontinue therapies in some people, which seems sort of heretical compared to what we used to talk about, which was only the need to be on treatment.
If you had to speculate, is most of this driven from on the physician side of things, or is it patient driven?
I think it's a combination of both. Based on my conversations with patients about this topic, there's some patients that say, I'm doing fine. I don't want to rock the boat. I'm tolerating the medication I'm on without any problem. Their preference is to continue therapy. Whereas there are other people that it seems like every time I see them, they ask, do I have to still be on this treatment? It's a pain in the neck, or I'm having side effects, or whatever. So I think it's a mixture of both.
Understood. So, can you tell us a little bit about how the group came to a agreement on this document?
This is a topic that's been discussed more and more often. So, ECTRIMS organizes a series of workshops. Leadership decided that this was an important topic to address. So, they brought together a rather sizable group of experts. It was not so much a formal consensus guidelines conference, but more of a informal workshop where there were presentations and moderated discussions. And then that led to drafting of the manuscript, which was then circulated to the attendees for further comment.
Can you tell us? I know it's a long document, a summary of what the highlights are of the recommendations of the paper.
One important aspect was conceptualizing the issues, which was talking about the evidence that relapses and MRI activity tend to decrease over time as people get older and the immune system changes. Secondly, progression becomes more noticeable over the course of the disease. Third, a review of the evidence that our available disease modifying therapies are more effective in controlling relapses and MRI activity than they are in preventing disability worsening. And so as a result, the need for these medications tends to go down over time. And also their efficacy tends to go down over time because the aspects of MS that they're most effective for become less prominent. And then finally, there is some review of the risks of medications, which thankfully are usually safe, but they do have some side effects and some safety issues. And those tend to accumulate over time. The cumulative risk goes up over time. And for some things, the risk seems to be greater in older people, in part because they have more comorbidities, they have other conditions. So conceptualizing these trade-offs, I think, was an important part of the paper. And then I think the other important part of the paper was the recommendation, which this may sound trivial, but the recommendation that these things have to be thought about when you're seeing patients in the office, and they need to be discussed with patients, particularly as patients age. You don't have to necessarily stop treatment in every patient, but you should at least be thinking about that as a consideration.
So one of the implications of this paper was for folks to kind of bring up a conversation. Should the clinician initiate that conversation or wait for the patient, or what would be best?
Well, I think that's the important point is that the clinician probably needs to initiate it. As I was saying, there are some patients that really dislike being on medications and they're impatient and they want to stop them. They start asking that right from the beginning. But most patients, after they've been told the importance of being on treatment and starting treatment early and being consistent with your treatment, it may not occur to them to ask, well, do I still need to be on this treatment? So I think frequently that conversation has to be initiated by the clinician.
Any recommendations for how someone who's in practice can operationalize these changes in others? They've been doing things all along, now need to kind of mix it up a little bit. So, any suggestions for someone who might be reluctant to do that?
First of all, they need to be familiar with the evidence that there is emerging evidence that in some people, disease treatment can be de-escalated or discontinued. It's a complex consideration. There are lots of things to think about. And they also need to realize that there may be no single answer for all patients. You have to sort of weigh the whole picture. The other, I think, important thing is emphasizing the so-called shared decision-making model. This is a perfect example where there's no right answer for every patient. And it's the clinician's job to initiate the discussion, frame the discussion, provide a summary of the available evidence for what the pros and cons are of continuing or discontinuing treatment, but also seeking the patient's input. What's important to them? Are they more scared about their MS flaring up, or are they more scared about being on a medicine that they may not need to be on anymore? And investigating their perspective. So that's the other part is that clinicians need to be aware of that concept, the shared decision-making concept. Things are much more likely to go well if the patient and the clinician come to a consensus shared decision rather than one or the other just dictating the approach.
Good explanation. What do the recommendations say about those who might be in special circumstances?
Yeah, well, so most of the article focused on older patients who have had MS for a long time, and particularly those who have been stable on treatment for a long time. And so then the question is, do they still need to be on treatment? And then the other scenario is someone with long-standing MS who's no longer having relapses, but is progressing despite treatment. So that's someone who's probably not benefiting from their treatment. The paper talks about some of the considerations for what to do in those situations, whether to stop or de-escalate therapy or not. And then there's the other situation that you talked about. So pregnancy, and that tends to happen in younger people and is a special circumstance where disease treatment needs to be modified, usually temporarily. And it's been a tricky question over the years because the most conservative approach would be to stop all treatments for everything when a woman's trying to conceive and when she learns she's pregnant. That's the safest thing from the baby's perspective. It may have other risks because the MS may flare up and so forth. So there's been a lot of discussion about how one might handle that situation. MS tends to become less active during pregnancy, so that's helpful. But sometimes that's not sufficient to just rely on the beneficial effects of pregnancy on the disease. So one of the things we've learned is that some of the initial medications, the interferons, glatiramer acetate, are safe during pregnancy. They're now approved by regulatory agencies for use during pregnancy. So that's one option. And then the other option that's gaining traction is to continue one of the fumarates right up until the time that the pregnancy is confirmed. They appear to be relatively safe, and then they're quickly cleared, so you could then just stop them. Or the other approach is to use one of the longer acting B cell depleting monoclonal antibodies, which
Yeah.
are generally cleared within a month or two. And during the early part of pregnancy, there's very little transfer across the placenta. And then when there is more placental permeability later in the pregnancy, those medications are gone, but some of their beneficial effects persist. That's a strategy that's been talked about for women with very active MS, but who would like to become pregnant. And so you time the infusions to just before, and then wait a month or two, then try to conceive. And then if pregnancy is confirmed, restart treatment after delivery. If pregnancy is delayed, then you might re-administer the medication and try again.
What about the long-term monitoring in those who discontinue therapy?
So it's important that the factors that seem to predict that someone will do fine with stopping therapy are not absolute. We still see some people who are older, whose MS has been stable for many years, and we discontinue therapy and their MS starts to percolate again, and they start to have active MRIs or even clinical relapses. So it's important to detect that reemergence of activity early. And so that's going to require clinical monitoring, periodic MRIs. They should be more frequent initially, and then they can be spread out. There's also been talk that serum biomarkers such as neurofilament light might be used to supplement MRI, because what you're really watching for is the early dramatic reemergence of activity. You want to guard against that. We can predict to some extent success, but in individual patients, sometimes we get a surprise.
Any final thoughts?
We've talked previously about risk calculators. This also is a situation where a more formal algorithm that would be available to clinicians would be very helpful. Because even though you can talk about patients as a group, what you really need to do is make a decision with the patient that's sitting across from you. There is work on that. I'm not aware of it in other settings in MS, but there is a risk calculator for treatment discontinuation that one of my colleagues here has developed and is in the process of testing.
I want to learn more about that. That sounds great. So I appreciate your time today, Dr. Cohen.